right. Hello, everyone. Thank you so much for joining us for the Duchenne Early Intervention Symposium. As folks start to trickle in, I will share just a little bit of housekeeping items to make sure that you're oriented to this webinar. Today, we are going to learn from 7 researchers presenting their data on the impact of early steroid treatment for patients with Duchenne, and that is to explore how early detection through newborn screening could affect this population. My name is Katherine Anderson, and I'm the Community Research Manager for Data Initiatives and Advocacy at Parent Project Muscular Dystrophy. And before I introduce our facilitator, let me orient you a little bit. Annie, if you go to the next slide. Today's webinar is being recorded, and it will be uploaded to PPMD's YouTube channel in the next couple of weeks. The format for the sessions is here on the right. So we'll learn a brief background of the history leading to this meeting and then touch on Duchenne natural history and what we currently know about early treatment. Then we'll jump into 2 blocks of platform presentations. So we'll hear from 4 researchers, and you're welcome to add your questions to the Q&A box while they're speaking, but we'll have all speakers together to answer questions after all 4 have presented. Then we'll have another 3 presentations and discussion afterward before we close out with some takeaways and next steps in Duchenne care. If you'd like to turn on captions, that should be an option for you, but be aware that the button might be visible on your navigation bar right now, but you might need to hit the More button to see the captions option. All right, so with housekeeping out of the way, let me introduce our facilitator. Annie Kennedy is the Chief of Policy, Advocacy, and Patient Engagement at the Every Life Foundation for Rare Diseases. Annie led the start of the Newborn Screening Initiative at PPMD and oversaw the New York State pilot. And with the Every Life Foundation, she continues to identify gaps in access to care and accelerate data collection in the neuromuscular space and beyond. So we're so grateful to have her facilitating the symposium today. Annie, you can take it away.
Sure. Thanks so much, Catherine, and thank you for the honor of getting to be here today. I've been asked just to help set the stage before we dig into our presentations and just remind us all how we got here to today. So in about 2009, our community really began to identify a need to build a newborn screening infrastructure for Duchenne. We recognized at that point that there were life-altering treatments on our near horizon, and our Duchenne community recognized a need to identify children as early as possible so that we could optimize health outcomes for individuals living with Duchenne. We also understood that there was an expansive public health infrastructure for screening and follow-up care for newborns in the US. And what we needed to do was build an infrastructure for Duchenne that could layer into that public health infrastructure. So we set out to do that. So in 2011, there was a meeting held at NIH looking at what the opportunities for newborn screening within neuromuscular diseases was. Soon after that, and over that same time frame, the CDC was funding a pilot within the state of Ohio for newborn screening in Duchenne. And within that time period, more than 37,000 babies were screened, and 6 were identified as having Duchenne. In 2013, PPMD launched the Duchenne Newborn Screening Infrastructure, which included 6 working groups, which over the course of now more than 10 years has really set out to help build a nationwide infrastructure for newborn screening in Duchenne and help answer some of the key questions that we needed to solve for before we could be ready for newborn screening in the US for Duchenne. Along the way, we also nominated a refined ICD code for Duchenne and Becker and worked with partners to seek an FDA approval for a screening kit for CKMM for Duchenne. This took a village, as with all things in the work that we do in the Duchenne community. This was a Duchenne community-driven effort, which took many, many partners across our community and across the patient organizations. This was an effort that has been touched by all federal agencies that serve our newborn screening ecosystem. This was an effort that has been held up by our clinical and research ecosystems all along the way, which we are going to hear about today. This was an effort that really required that we bring together the experts in newborn screening with the experts in Duchenne and really build a new space where we convene together. And this was an effort where we could learn from the patient communities who had come before us. This started in the early 2000s, but it continues today from those who are implementing newborn screening programs on the state level, and then continuing to evolve from those learnings as follow-up care and those communities evolve and the natural histories of those diseases evolve. And then we've benefited from the work of our industry partners, both in funding many of these efforts, as well as the data collection efforts. And then, of course, very importantly, as therapies have begun to be approved in Duchenne so that we can have life-altering therapies that are available to those who are screened and identified in a timely way. So just to go through this timeline very quickly, as I said, all of this really started in early discussions in 2009, the first pilot in Ohio in 2012, and then the launch of PPMD's infrastructure effort in 2013. We didn't set out to do a pilot in New York, but we realized very early that we needed another pilot to then test all of that work we had done to develop those provider-facing, patient-facing, and new screening methodologies in another large state. And then to be able to develop a nomination package for the federal recommended uniform screening panel. That then brings us to where we are today. That recommended uniform screening panel nomination is now underway and under consideration. And in the meantime, we have also seen efforts some led by PPMD, some led by others, to have states introduce newborn screening for consideration in states. We now have 2 states that have implemented those screens and 2 that are moving this state legislative efforts forward. We'll talk more about that at the end. All along the way, every single stakeholder has had incredible contributions to make and continue to do so. We have also published all of these efforts so that all of this can be available to the Evidence Review Committee, to the federal and state partners who need to understand Duchenne and understand the implications for newborn screening. And we are continuing to learn. What we understood about Duchenne in 2009 and 2013 is very different about what we understand today, and we are going to continue to learn. Today, though, we are so grateful to the clinicians and academics and research partners who very early on set out to start to collect data about those who were being identified in a timely and early way. Those data collection efforts were nascent at that time, but we have posed the question today, how is timely detection through newborn screening impacting children with Duchenne? While those, again, data collection efforts were nascent, through these working group efforts, we have now learned how to do this work in a unified way, how to have consistent data elements as we collect this data from those who are being identified in early stages. But those we will learn from today started leaning into this very early, and we are grateful to you for your work. So with no further ado, let us hear from the first of our presenters today. And I'm going to stop sharing and turn this over. Our first presenter today is Megan Iamarino, who is here to orient us to our current landscape of Duchenne natural history and care. Megan serves Duchenne patients as a physical therapist with Nationwide Children's Abigail Wexner Research Institute. Nationwide's Duchenne programs are certified care centers through both Parent Project Muscular Dystrophy and the Muscular Dystrophy Association. As a member of the multidisciplinary team, Megan supports clinical and research projects to better understand and improve Duchenne care. Welcome, Megan.
Thank you. I'm very excited to be here, and I appreciate and I'm excited. So thank you all for inviting me to speak. As Anne said, I will be, let's see if I can get this shared. I will be presenting on the natural history of Duchenne from everything that we know now. Is everybody able to see my screen? Perfect. Thank you. Okay. All right. So Duchenne muscular dystrophy. We know a lot about DMD. There are so many aspects of the disease that have been documented and researched over the years, and still, yet there is much more to learn. From the basics, we know the inheritance pattern, we know well documented the incidence and prevalence of Duchenne, we know the age of diagnosis, which is typically around 5 years of age, and the events that are usually result in a diagnosis. These include incidental findings of elevated CK, a persistent and progressive weakness that may look like an inability to keep up with peers, that is not responding to traditional therapies like physical therapy or strengthening programs, and also difficulty with stairs. We also know the typical trajectory of the disease. So it's usually diagnosis at around 5, and then a loss of life in late 20s or early 30s due to either respiratory complications or cardiomyopathy. We also know that there is currently no cure. And it's crazy to think that before the 1980s and the work of the CIDD group that showed corticosteroids, prolonged ambulation, preserved cardiac function, and slowed pulmonary decline, there were no treatments at all available for individuals with DMD. And even after that, it wasn't until 2016 that the first disease-modifying agent was approved, and that was eteplirsen. Now in 2025, we're in 2025 now. Now we have 8 currently approved disease-modifying therapies for Duchenne, from exon skipping to gene replacement therapy, to other small molecules aimed at maintaining muscle function, and also other steroid alternatives. However, prednisone is still the only approved therapy that has no age restriction or is limited by a child-specific mutation in the DMD gene. We all hope that with ongoing clinical trials in younger and younger children with DMD that we all know are currently going on, we can identify treatments that are safe and efficacious to all ages of the disease. So DMD is a multi-system disease, but primarily of muscle. So we typically think of this in areas of respiratory function, cardiac function, and motor function. Muscles of respiration are not spared, and a combination of dystrophin-reduced muscles of inspiration and expiration, and also a shift in posture from a prolonged scoliosis, progressive and prolonged scoliosis. This can lead to decreased lung function. These symptoms are usually limited to those who are non-ambulatory. And in fact, in a retrospective look at pulmonary function, researchers have found that the annual rate of pulmonary decline significantly increases once ambulation is lost, and that those who lose ambulation earlier have a greater rate of respiratory decline. With that being said, respiratory dysfunction can present early, and it's typically manifested as something along the lines of obstructive sleep apnea, which can be diagnosed and treated using BiPAP, but diagnosed through sleep studies. And this is why care guidelines suggest early and ongoing monitoring from a young age. Similarly, cardiac tissue is also impacted by a lack of dystrophin. Typically, impairments in cardiac function kind of follow the same trajectory as pulmonary function, in that they are usually presenting in the early to late non-ambulatory phase of the disease. Like pulmonary function, there appears to be a relationship between cardiac function and motor function. A recent retrospective study found a significant relationship between age and loss of ambulation, or age at loss of ambulation, and left ventricular ejection fraction, which is how we look at cardiac function. And this suggests that an earlier loss of ambulation is associated with earlier impairments in cardiac function. Again, Like pulmonary function, clinical monitoring is critical, as early heart failure can go unrecognized without non-invasive monitoring such as ECGs, regular annual ECGs, echoes, or cardiac MRIs. Treatments are available with ACE inhibitors and other pharmaceuticals, and some are recommended to begin before the age of 10, which may even be before the age of loss of ambulation. So again, care guidelines recommend early and ongoing monitoring of cardiac function. And motor function. This is my area. So this is how we typically think of motor progression in DMD. We think 5 years of age. This is where we have overt muscle symptoms, something that leads parents and or clinicians to a diagnosis of Duchenne muscular dystrophy. By about 8 to 10 years of age, we have what we call the transitional phase. This is where there's more muscle damage, especially in the proximal muscles. Children are having more falls due to fatigue, and that's where we start talking about energy conservation and the need for power chair or other tools in order to conserve energy. By about 15 years in the non-ambulatory phase, we start talking about custom seating in order to make sure that patients are comfortable and sitting upright and also not having any kind of sores or wounds from their seating system. And then in that 20 plus years of age, that's where we really are looking at that kind of pre-terminal stage. This is how we typically think of motor progression in DMD. However, this is kind of nicely packaged and certainly oversimplified when this is the reality of what motor function looks like for boys with Duchenne. This, as a physical therapist, gives me anxiety because it makes me think like, do we actually know anything? We know a general trajectory, but there's so much heterogeneity in the presentation of motor function in the disease that I think, is there anything that we actually know? But with a combination of clinical expertise and math, so specifically a cohort trajectory analysis, which groups boys with similar performance trajectories based on longitudinal performance on the North Star, we can start to make sense of this heterogeneity in Duchenne. And what this does is it gives us tools to identify expected trajectories early and then plan accordingly. So the more we know and the earlier we know it, this can help assist clinicians with proactive planning and management to optimize outcomes in all children. However, caution, because most of the documented history that we have of boys with Duchenne is in boys who are greater than around 5 years of age and above. So taking a look back at the historical paradigm, parents often report that what they feel are overt symptoms in much younger years of age. So even before the age of 5, they often report that they noticed delays early and were dismissed by primary caregivers. And it's also reasonable to believe that there is undetected muscle damage in these early years, which can be evidenced by highly elevated CKs at birth. So now it's time, now that we know a lot of what we know about years 5 through adulthood, it's time to focus a little bit on what we know about the development in kids who have been diagnosed in infancy or in early childhood. So many researchers started to explore the development in these boys at the younger age and found that just like we know there was the first age of, or the age of a missed motor skill, which would be independent ambulation, that even before that, there are delays in motor skill. This specific graph is of the Bailey, the gross motor subtest of the Bailey, which is a developmental assessment, and the line and down the middle, And the line down the middle here is what the typical trajectory of development is. So even in our youngest kids, kids that are 6 months, 12 months, 18 months of age, they primarily fall below the average trajectory. And as they age, even before 5 years of age, they slowly fall off that trajectory curve. So the older they get, the more farther away from the curve they fall. We also see this in the scaled scores. So this is a normative curve with 10, scaled score of 10 being the average performance for a child. And a large majority of the children fall not only below the average, but below the average range, which would be 8 to 12, and fall even in the ranges of 5, 4, 3, which are moderately to severely delayed in motor skills. Further studies or other studies have shown similar results. So this was from a study from 2013 that looked at historical controls in boys with Duchenne, showing pretty similar, a significant motor delay. So is there anything that we can do for these young children? Recent work has shown that young boys may benefit from steroid initiation earlier than 5 to 6 years of age. Dr. Connolly did a prospective multi-center study exploring the impact of twice-weekly steroid treatment in young boys with Duchenne, and found that compared to a historic untreated control, those who started and initiated therapies early had improvements in scaled score, a statistically significant difference and improvement in scaled score compared to those who were not treated with weekend steroids. Further, there was some modeling done by a group, Smith et al., who did a microsimulation model that estimated the impact of newborn screening for Duchenne. They compared typical care models, so this was data from real-world registries, including PPMD's Duchenne registry, to one of a group that would be identified through genomic screening at newborn. In the newborn screening model, they assumed steroid initiation at presentation of first symptoms. So this would be in the early ambulatory phase. And then they predicted that with this type of nationwide program, there would increase the number of boys with Duchenne that are still ambulating by the age of 12 by almost 11%. Further, other retrospective studies had looked at the impact of corticosteroids and further grouped the children into slower progressing, moderate progressing, and fastest progressing groups, and then also grouped them based on steroid exposure. So early exposure, which would be those who had exposure to steroids before the age of 6, and that would be the blue lines. Late exposure, so that would be exposure after the age of 6, and then which would be the red lines, and then steroid naive boys. And what they found was, especially in the moderate progressive cohorts, that there were a significant improvement in both in performance on timed function tests compared to both other groups, suggesting again that earlier steroid exposure is more beneficial. So we typically focus on motor, respiratory, and cardiac function, but cognitive and language are also impaired. We know it's pretty well documented that there's a higher incidence of autism, ADHD, and other behavioral issues associated with Duchenne. So while unlike the progressive muscle damage, cognitive impairment is static and remains stable throughout the years. The earlier we identify these boys, the earlier we can start supportive therapies, such as speech therapy, occupational therapy, counseling, and behavioral therapies. And these are all with the goal of optimizing performance in school and social and life situations. This, I feel, is kind of the most important slide. With everything we know about Duchenne, specifically, that's a multi-system disease that impacts more than muscle function. And even in the fact that we have like kind of blown up in the treatments that are available to these to individuals with Duchenne, the age of diagnosis has not improved since 2009. There is still about 2-year delay in diagnosis between first noted signs of DMD and confirmatory testing. And that does not include the parental concerns that are typically dismissed by pediatricians for years. Further, there are racial and ethnic disparities impacting time to diagnosis. The time between age of CK, of taking a CK and a referral to a neuromuscular specialist is significantly later in Black children and Hispanic children compared to white and non-Hispanic children. And further, the same trend is followed through by confirmatory genetic testing, that it's earlier for white cohorts compared to both Hispanic and Black cohorts. So in conclusion, Duchenne is a multi-system disease. It's not just a disease of skeletal muscle, and we need to consider all the impacted domains of the child when we're discussing early identification and early intervention. Racial and ethnic disparities in time to diagnosis are well documented. We found earlier exposure to corticosteroids have shown to improve motor function and perhaps change trajectory of the disease. There's timely, and steroids also improve pulmonary and cardiac function, and early identification can lead to earlier utilization of supportive therapies to improve overall functions and outcomes. And to end on a positive note, newborn screening, I believe, can provide equal opportunity for earlier diagnosis, timely medical management, and optimization of outcomes for individuals with DMD. Thank you.
Thank you so much, Megan. That was really incredibly important background information. We really appreciate you doing the level set for us today. So our first research presentation today will be from Lauren Bogue. Lauren is the lead curator for the Duchenne Registry, which Megan referenced in her presentation, at PPMD. She's a graduate of the Indiana University Genetic Counseling Program. And prior to her current role at PPMD, she worked in a variety of clinical, telehealth, and industry settings with a special interest in neurology and X-linked conditions. So Lauren.
Hello. Oh, can you hear me or am I staticky?
We hear you.
Okay, great. I'm getting a tiny bit of feedback, so let me know if the volume gets strange. Well, thank you so much for letting me be here today. My name is Lauren Bogue. I'm the lead curator for the Duchenne Registry at Parent Project Muscular Dystrophy. And I am excited to have the opportunity to share our abstract titled Earlier Steroid Initiation is Associated with Later Loss of Ambulation in Participants of the Duchenne Registry. Oops. The data used for this research comes from the Duchenne Registry, which is a long-standing patient-reported registry and research study, which is owned and managed by PPMD, and which collects a variety of data from participants on a recurring basis over time. As part of their consent for the registry, participants agree for their de-identified data to be used for research by PPMD and other third parties. Pertinent to this research that we're talking about today, the registry collects information about age of diagnosis, presenting features, initial age of full-time wheelchair use, age of corticosteroid initiation, and genetic variant data. And that genetic variant data is formally curated from submitted genetic test reports by registry staff who are trained as genetic counselors. Given the data set we have available to us, we were keen to assess whether the age of corticosteroid initiation could demonstrate an influence on the age of loss of ambulation, and specifically to consider this question of trying to achieve early corticosteroid initiation versus the more typical general population initiation time period as it stands right now. And so in our study, we're going to use these two research questions or these two registry questions to help answer our research question. So at what age did full-time scooter or wheelchair use begin? We're going to use that as our age of loss of ambulation. And how old were you when you first started any corticosteroid treatment? We're going to use that as our age of corticosteroid initiation. We also know that there are many factors that can impact an individual's disease progression. You saw in our previous presentation, the grids were like there's so much variety and difference in the actual trajectory. And so if there can be a lot of variables that are impacting disease progression, that could in turn impact the results of our primary question. Now, because the registry houses highly detailed genetic variant data, we also elected to explore whether controlling for a subset of genetic variants that we determined to be highly Duchenne specific, whether that could enhance our assessment. From the registry participants, or from the registry, we wanted to select participants for inclusion based on a combination of criteria. We needed to know that they were relevant for the study. So we have female participants in the registry. We looked at males for this study. We also needed to know that they had all the data points we needed to conduct this particular set of research questions. We did limit our data to those who lost ambulation at ages 5 or older. The logic being that, based on the natural history of Duchenne, someone losing ambulation under the age of 5 wouldn't be consistent with that natural history and would suggest either some serious accident or other health condition that could otherwise confound the results. We also limited our data to those who had initiated steroids by age 13. Again, the logic being based on natural history that if a person has Duchenne and has never been treated with steroids, that we'd expect them to have lost ambulation by age 13. And so if we're looking at people whose initiation was at 13 or older, we sort of lost the time window by which we'd expect it to influence their loss of ambulation age. And so the N for this study, after applying these selection criteria, is 320 people who met all these criteria. For the purposes of our analysis, the cohort was then categorized in a couple different ways. We categorized based on kind of some buckets of age of steroid initiation, and then subsequently also conducted research on subgroups based on a subset of variants. So we grouped anyone with a reported steroid initiation age 5 and up, we grouped them together. That's kind of like the standard steroid age of initiation. And we compared those to groups that may meet a potential definition for early steroid initiation. We compared that to a very strict definition for that of individuals who started steroids under age 4, and then also repeated analysis for anyone who started steroids under age 5, inclusive of all those under 4-year-olds as well. And then the analysis for the less than 5 and over 5 groups were then repeated while controlling first for a subset of 9 genetic variants and then for a subset of 3 variants. And for any of these groups, essentially what we did is compare it for this group versus this group. Is the average age of loss of ambulation the same or expected to be different based on the statistical calculation? Now, a brief comment on how we selected the variants that you see here that we ultimately used as kind of our subset that we were considering highly Duchenne specific. This first subgroup A, we selected these variants based on Duchenne specificity and frequency within a publication, a cohort published by Flanagan et al. In 2009. And we defined this as variants that had at least 5 cases of Duchenne phenotypes without any cases of Becker or intermediate muscular dystrophy listed in that cohort. And then from these 9 variants, we then had 2 genetic counselors review each variant using contemporary data sources to try to assess, in their opinion, could this be considered highly Duchenne specific, agreed upon by multiple people. And essentially that was confirming that there wasn't any valuable or quality evidence of there being a Becker case reported in the literature for these variants. And for each of our calculations comparing these groups and their age of loss of ambulation, our preferred calculation was to use a t-test. We used two-tailed Welch's. We didn't assume normal variance or equal variance. And we set a p-value of 0.05 as our cutoff for determining are the average age of loss of ambulation the same between the groups we were comparing. So p-value less than 0.05, we're going to say, hey, we expect that these average ages of loss of ambulation are truly different between groups. These next couple slides are going to include 4 tables that summarize our calculation. These are the first 2. So each table is sort of organized as follows. It's going to have just a little comment to orient us to kind of which subset of the group we're looking at, which categories of steroid age of initiation are we looking at. You will see average age of loss of ambulation for each group we're looking at based on our data, and then you'll see the p-value for the t-test. So in our first grid, this was the comparison between those who initiated steroids ages 5 and up to those who initiated at under age 4. You can see that this N is small, this N of 23, and we truly expect that this is a driver for why this p-value is not significant when we only look at less than 4 to these 5 and up. And when we increase the size of this early initiation group to include under 5, so all these individuals plus people who were age 4 at the time that they initiated steroids, this N gets a lot bigger. The averages essentially stay the same compared to what we were looking at for the under 4, and now we have a significant p-value. So in our title where we're saying, hey, we expect that early age of steroid initiation can add years of ambulation or improve length of time to being non-ambulatory, this is the primary calculation we used in that statement. These bottom 2 tables reflect our calculations using subgroups of our cohort that were those variants that we were controlling for. So here's the 9 variant group. And this group had a statistically significant difference in age of loss of ambulation. But now that we've controlled for these variants, we have the statistical significance, we also see this age of loss of ambulation, the averages between the 2 widening compared to these up here. And this would essentially support our hypothesis that controlling for variants could have a role in better understanding treatment outcomes. The N for the 3 variant group, you can tell, again, these are some small N's here as we start to narrow our cohort further and further. This really wasn't really amenable to doing a t-test in the way that these others were. We did use an alternative calculation called the Mann-Whitney that assesses rank order. So if I compare the value of 2 similarly ranked items, is one group likely to have a higher value at a similar rank? You know, this had a significant p-value because of the small size and this alternate calculation. We didn't use this necessarily for any kind of conclusions regarding these 3 variants. Our data set provides evidence that categorically we can think of earlier treatment as having a positive clinical effect, all the way to thinking of that endpoint of loss of ambulation. And from what you've heard of natural history, that timing of loss of ambulation then has downstream effects on other aspects of a person's health. But earlier treatment requires earlier diagnosis. Again, from the previous presentation, we know that timing of appearance of first symptoms, then there's a delay to diagnosis. And our data set actually then supported a delay from diagnosis to steroid initiation. So for people in this initiated under 5 group, the average age of diagnosis was 3 or under. Now, these people were symptomatic. They indicated to us what the symptoms were that led to their diagnosis. The vast majority, to the tune of 95% or better, had symptoms. So these were just very perceptive parents or clinicians, with very few people who were truly incidentally identified. But that means we have to change how we're diagnosing people if we really want to achieve this category of starting steroids at an early age. And another comment would be that future studies assessing outcomes could consider ways to control for objective factors that may impact disease progression to help tease apart some of these benefits. I want to express our sincere gratitude to every participant of the Duchenne Registry whose time and effort made this research possible. And thank you so much for your attention, and I look forward to answering any questions at the end of this set of presentations or via email anytime. Thank you.
Thank you so much, Lauren. This was really powerful to see what we can learn from such a long-standing data repository and registry, and also the power of data that is contributed by the patient community. I know we'll dig into this a little bit more during the Q&A. So thank you so much for your presentation. So next, we are going to hear from Dr. Emma Scheffaloni, And I just want to make sure we can switch presenters. Okay, I'm going to start Dr. Shefaloni's introduction. So Dr. Shefaloni actually was a part of the infrastructure effort that I introduced at the beginning today. She led the clinical care working group and also helped work with the Newborn Screening Translational Research Network on the longitudinal data collection efforts and led a clinical working group within that effort as well. She is the Robert C. and Rosalind H. Griggs Professor in Experimental Therapeutics of Neurological Disease, Professor of Neurology and Pediatrics at the University of Rochester. She's an Associate Chair for Research in the Department of Neurology and Director of PPMD's Certified Duchenne Care Center. So I'm delighted to introduce Dr. Shefaloni.
Hi, can you hear me and can you see my screen?
Perfect. You're in presenter mode. So if you want to switch that out.
Can you see my slides?
We can, but we see your, but we see two slides at once. So if you want to just switch it out of presenter mode.
Sorry.
That might be under display settings at the top.
Yep,
Sometimes
go
it
to
lets
the
you flip
middle.
back and forth.
Yeah,
Right.
because I
Yep.
have to swap presenter view.
Yes.
Yep, that one. Yep.
That's better.
Yep, there you go. You're done.
Okay,
Perfect.
sorry about that. Good morning, and thank you to PPMD for organizing this great meeting. Thank you for the opportunity to present on this study, motor function benefits with early corticosteroids initiation in Duchenne muscular dystrophy, and adjusted cross-trial comparison. And I'm presenting on behalf of the whole group of authors. So the objective here was to compare patient who initiated versus did not initiate a daily corticosteroids, either prednisone or deflazacort daily, between the ages of 4 and 8, and to compare the 12 months motor function outcomes. So we have heard quite a bit already about a beautiful presentation about natural history and motor outcomes in Duchenne. So the primary three outcome that we used for this particular analysis was the North Star ambulatory assessment. We've heard quite a bit about this scale. It's an ordinal scale with a maximum score of 34. And just for, I know we have a broad type of audience, this is a scale that has become extremely well known and used in clinical trials in the past several years, but also it's a scale that we really use routinely in real life setting and in clinic. And basically it assesses a number of motor function from 0, unable to do, 1, able to do but with modification or help, and 2, able to do without any help. And then time function tests, which have also been extremely well studied in natural history and in clinical trial, the time 10 meters walk, run, and the time rise from supine, which is really, the Gowers maneuver and how long does it take a kid to get up from the floor. We have an immense amount of very helpful natural history data. And we know that these are measurements that are also meaningful, and they predict well the progression of the disease. So, and what we did is we used 2 trials that have completed. One was the 4 DMD clinical trials, finding the optimum steroid regimen for Duchenne muscular dystrophy. And the other was the Polaris DMD. This was a phase 3 placebo-controlled trials of edazelonexant in Duchenne muscular dystrophy. And because these were obviously 2 cohorts from 2 different studies, we had to implement some statistical managing of the data, and we use a propensity score weighting to adjust the baseline characteristic known to be prognostic. And we're going to talk a little bit more about that. But basically, since we're comparing patients from separate trials, we needed to make them as similar as possible at baseline. And to do so, subjects in the Polaris DMD were assigned weights so that their weighted average baseline characteristic matched the baseline average for 4DMD. And we did the baseline averages for age, the North Star, the 10-meter walk run, the rise from the floor, weight, height, and BMI were matched in this way. And there has been well-published data about this particular statistic methodology. And so the weights were based on propensity score model. So here there is a little bit more about the patients and treatment in the two groups. So in the 4DMD, we used 65 patients that were treated with daily prednisone of 0.75 milligram per kilograms, and 65 patients in the arm with daily deflazacort 0.9 milligram per kilogram. They were between the age of 4 and 8. They needed, as an inclusion criteria, to be able to rise independently from supine, and they were not allowed to have used either current or in the past steroids for no longer than 4 weeks, and no investigational drugs in the prior 3 months. The time of enrollment, you can see it in the last lines here. It took about 3 years to enroll for the whole study between 2013 and 2016 in that many sites and countries. For the Polaris DMD, we use obviously the placebo arm, and steroids were not permitted. We had an N of 43. They were aged between 4 and 8. They were, as an inclusion criteria, as long as they were able to rise independently from supine in equal or less than 10 seconds, and no steroids in the last 24 weeks. They were also not allowed investigational drug in the prior 4 weeks, but there was one exception for one patient that was on eteplirsen for more than 24 weeks. The enrollment took about a year, from 2018 to 2019, and those are the sites and country. Just to clarify, in the Polaris overall, 127 out of the 131 patients, so 97% were steroid naive. There were actually 4 patients that have used steroids for more than 24 weeks prior to the study, versus in the 4DMD, really was an exclusion criteria, so they'd never been exposed to steroids. So in a way, the differences in inclusion criteria will tend to be biased a little bit against benefit on initiating daily steroids, because the no steroid group is excluded from having very long rise time, allowed eteplirsen, and it was a little more recent in time, 2018-19, and we know the standard of care tends to improve over time. So after the matching, the baseline characteristics were obviously well balanced after matching, because that was the whole purpose of the matching. So you can see here for the daily steroids, before waiting and after waiting, they were all exactly matched for age, rise from floor velocity, the 10-meter walk run, the North Star, weight, height, and BMI. And really, the statistical approach is designed to exactly match the baseline mean, so it's expected to see what we're seeing here. And the reason that we weighted this particular list of baseline characteristics is because all of these characteristics have been shown to be prognostic for a 1-year change in motor function in Duchenne muscular dystrophy. So, and especially the combination of multiple functional measures, including the North Star and the time function test, is really being well demonstrated to be very helpful. And these are our results. You can see that the daily steroids has significant improvement in the North Star, the 10-meter walk run, and the rise from floor with positive values, meaning improvement in all of these 3 motor outcomes, versus the no steroid group actually having a negative, as expected, with the natural history of the disease over a 12 months period. Also, very importantly, this concept of minimally clinically important differences. So, okay, these were statistically significant, but what do we know about these 3 motor outcomes, about clinically meaningful differences? And here you can see the blue bars are for the treatment effects. So the outcomes differences between the groups with daily steroids versus no steroids, and all exceed the MCIDs, or minimal clinically important differences, for all. Obviously, for the North Stars on the left, it's a range. Usually about 3 is considered clinically meaningful, and then here is for the velocity, 10-meter walk run velocity, and the rise from the floor velocity. This is all also based on very well published and studied methodology. So in conclusion, as a cross-trial comparison, confounding is possible due to unobserved differences between non-randomized group, and patients with Duchenne age 4 to 8 experience substantial and clinically meaningful motor function benefit in the year following initiation of a daily corticosteroids compared to similar patients who do not initiate a corticosteroids. In the context of an average age of Duchenne diagnosis of 5 years and frequent delays between first symptoms and diagnosis, these findings highlight the value of an earlier diagnosis to allow for caregivers to discuss use of corticosteroids and to increase the opportunity for meaningful functional benefits in the early developmental years. And we want to acknowledge and thank the patient and families participating in the 4DMD and the Polaris trials, Catabasis for sharing data from Polaris DMD, and of course PPMD for facilitating this analysis. And we are planning to dig a little bit more in this comparison type of study by comparing, for example, the percent of patients with the time rise from supine greater than 5 seconds, as we know that is very well correlated with the progression of the disease and loss of ambulation. Compare also adverse effects such as weight gain and growth retardation in the treated versus untreated. And then maybe do more subgroup analysis by 1 year age categories, especially focusing on the very young, especially the 4 to 5 years old. And that's in the plan as a future actionable. Thank you very much.
Thank you so much, Dr. Scheffaloni. It's really wonderful to see what's already been done and then also what you're continuing to plan to do. So thank you for your leadership in this space. We really appreciate you. So next we are going to hear from, let's see, we have Casey Little. Casey is a medical student at the University of Virginia School of Medicine with a special interest in pediatrics. She's been working with the UVA Department of Developmental Pediatrics to study mental health and quality of life in patients with neuromuscular disorders. And a part of that work will be shared with us today. So Casey, thank you for being here.
I forgot to unmute myself. Hi, everybody. It's nice to be here. So the project that I'm presenting is titled Corticosteroid Therapy. Oh, sorry, can I go back? Corticosteroid therapy and age in patients with Duchenne muscular dystrophy. I did this with my research mentor, Dr. Anna Jesus. So we already have had a good discussion about the use of corticosteroids in kiddos with Duchenne, with pros being improved strength and prolonged independent functioning and slowed disease progression. Though some cons that we were thinking about were the effects of behavioral changes, weight gain, decreased bone density, and HPA access suppression. We're really focusing in on this behavioral changes and focusing on how there's really minimal evidence regarding the optimal age to start steroids and how starting steroids may affect the long-term mental health outcomes in these kiddos. And so the objective of this study is to investigate the potential association between age and corticosteroid initiation and patient-rated quality of life and report of depressive symptoms. So for this study, we had patients that we recruited through the UVA Pediatric Neuromuscular Clinic. This is a multidisciplinary clinic at UVA where we bring in all of our patients with Duchenne muscular dystrophy and connect them with multiple different specialties, including pulmonology and cardiology. And during their visits with our neurodevelopmental team, each patient completed the pediatric quality of life inventory for Duchenne muscular dystrophy. This is a disease-specific health-related quality of life scale. And then they also completed the children's depression inventory. And this is a self-report measure on the presence and severity of depressive symptoms within 2 weeks of completing the survey. Inclusion and exclusion criteria, really the patient's ages ranged from 50 to 40 years, or excuse me, 5 to 40 years old. They had to have a confirmed diagnosis of Duchenne muscular dystrophy, and they had to speak English. Of note for each of these surveys, if any participants were unable to read or complete the questionnaires independently, a research assistant administered the questionnaires. So for results, for our statistical analysis, we used two-tailed t-tests, and we used a p-value of 0.05 to determine significance. We had a total of 35 participants. 25 of those were on corticosteroids. We had 14 who had started the corticosteroids after age 5, and 7 that started before age 5. For our patients, we found that quality of life scores were similar in all domains except the worry domain, in which patients who started corticosteroids less than or equal to the age of 5 had lower levels of worry than those who started above the age of 5. We also found that regarding their depressive scores, those who started corticosteroids when they were above 5 years old had reported lower depressive symptom scores than both of the other groups. So kind of the meat of this is talking about the study and implications for the future. So we found that those who started corticosteroids at less than 5 years of age reported lower levels of worry, but greater depressive symptom burden than those who started at ages greater than 5 years old. Strengths of this study is that we had patient-reported outcomes in many of the studies that I had seen. Many measures were parent-reported, and we thought it was really important to have the kids themselves report these measures, and that was something that we were able to achieve. We also included a wide variety of kids in multiple different disease stages, and that was a strength of our study. For limitations, we did have a small sample size, and because of this, we weren't able to stratify our results by disease stage, for example, ambulatory status or cardiac or respiratory function, which could limit the analysis of or the use of our data. Secondly, we had a lack of patient privacy during the interviews. So their parents were in the room as they were completing that, which could have introduced some bias into our results. So in conclusion, we found that the age at which patients start their corticosteroids tends to vary, though the age of initiation may be associated with mental health outcomes later in life. And so more needs to be learned about the best age to start these corticosteroid therapies in this population with regard to their mental health. Future plans for this study is we are still collecting data, and so we are hoping to have enough participants that will eventually be able to look at this data with respect to disease severity and stratify based on that. Here are my sources, and thank you.
Casey, thank you. First of all, thank you so much for studying this really incredibly important area that really matters to our patient community. So thank you for being here with us today and focusing on this area of neuromuscular care. We really appreciate that. Okay, our next speaker in this section is Dr. Crystal Proud. Dr. Proud is a board-certified pediatric neuromuscular neurologist serving patients at Children's Hospital of the King's Daughters, directing a clinic that is certified by both the Muscular Dystrophy Association and Parent Project Muscular Dystrophy, She also oversees the Elevidys treatment program at CHKD and has served an active role in the Neuromuscular Center's clinical trials. So Dr. Proud, welcome.
Thank you. It's a pleasure to be here today, and I will review the 2-year efficacy and safety outcomes of delandistrogene moxeparvovec in DMD for the EMBARK phase 3 clinical trial. As you're aware, delandistrogene moxeparvovec is an adeno-associated viral vector-based gene transfer therapy for the treatment of Duchenne muscular dystrophy. The viral vector serotype RH74 carries this transgene, which ultimately encodes for a shortened version of dystrophin to be produced in the patient's bodies. For those who receive it, it is approved in the US and other select countries as well. Today, we'll review the 2-year efficacy and safety outcomes with week 12 and 64 expression, and then we'll also review week 52 muscle MRI outcomes. Here is the EMBARK study design. Patients were randomized 1-to-1 to receive in part 1 of the study either a single IV infusion of the product, delandistrogene moxeparvovec, or an IV infusion of placebo. They were followed for 52 weeks, and then in part 2, they would receive the opposite of what they received for an infusion in part 1. They then were followed for various outcomes and will continue to be followed in an open label extension study labeled 305. In order to participate in the clinical trial, they had to be ambulatory boys between the ages of 4 to less than 8 years of age, with a confirmed Duchenne muscular dystrophy diagnosis involving a mutation contained within exons 18 through 79 inclusive. They had to have a North Star Ambulatory Assessment score of more than 16 and less than 29, a time to rise of less than 5 seconds, and had to be on a stable dose of corticosteroids for 3 months. In addition, they had to be negative for the antibody testing. Because there was not a placebo arm due to the crossover design, this 2-year EMBARK data will be compared with an external control cohort of patients with Duchenne muscular dystrophy. These are going to be a cohort of patients that were obtained from the studies that you see listed here, including the patients in those studies that received only the corticosteroid regimens. So this was the 4DMD study, the BioMarin Pro DMD-01 study, and Synergy. In the pre-specified external cohort, they had to be similar to the enrollment criteria for the EMBARK clinical trial. So you see the criteria listed here, and then a process by which we call propensity score weighting took place to be able to make sure that the 2 groups were similarly matched so that they could be compared over time. And the propensity score weighting was based on the baseline age, North Star score, time to rise, 10-meter walk run, height, weight, and BMI to make sure that these 2 groups were able to be comparable. So what we can see here is that the baseline characteristics for those patients that received delandistrogene moxeparvovec in part 1 of EMBARK match nicely to those in the external control cohort that we'll use as a comparator after this propensity score weighting. Here we see the EMBARK Part 1 functional outcomes at 2 years. And what we can identify is that there is a statistically significant and clinically meaningful functional benefit that was demonstrated compared to this external control cohort that was well matched. I'll call your attention to the line that is vertical at 0, and to the right of that line indicates that the results would favor treatment with delandistrogene moxeparvovec. Let's look at this a little closer, and what we can see here is that on the North Star Ambulatory Assessment score, the square all the way to the left, those patients that received delandistrogene moxeparvovec had improved on their score by 2.63 points at this 2-year time period. This is in comparison to the external control cohort that declined by 0.25 points. So there was a difference in total of 2.88 points on the North Star between these 2 groups, and this was statistically significant. If we look at the time to rise, a very common test that we have done every 6 months in clinic, and we utilize it for clinical research outcomes, we see that the treatment group had a time to rise that became longer by 0.65 seconds at the 2-year time period, whereas the patients in the external control cohort had a prolonged time by 2.71 seconds in that same time period. So this was a difference of 2.06 seconds, which was statistically significant. If we look at another test we routinely perform, both in clinical practice and clinical research, the 10-meter walk-run test, we see that the boys in the delandistrogene moxeparvovec group had an improvement and walked faster on their 10-meter walk-run at 2 years by 0.04 seconds, which is probably about stable overall. But this is in contrast to the external control cohort, which had a prolongation of their 10-meter walk time. It took them longer by 1.32 seconds in this same time period. So the difference between those two values is 1.36 seconds, which is also statistically significant. So we've looked at functional data over 2 years. What about the biopsy data? So what we can see here is that delandistrogene moxeparvovec microdystrophin expression was sustained from week 12 to week 64. And this is demonstrated by 2 parameters that we use to examine in muscle biopsies of treated patients in the clinical trial program, the Western blot and the percent dystrophin positive fibers. So these were maintained between weeks 12 biopsy and week 64 biopsy. Safety is, of course, an incredible priority for us as we look at this therapeutic strategy. And so what we can see is between weeks 52 and 104, 23.8% of patients experienced 34 treatment-related, treatment-emergent adverse events. 1 patient experienced 2 episodes of rhabdomyolysis, both of which resolved. And importantly, there were no treatment-related deaths, discontinuations, or clinically significant complement-mediated AEs. It's important to talk with families about when to expect potential adverse events. And what we can see here is that within the first 2 weeks, the highest percentage of adverse events that we see are those including vomiting, nausea, decreased appetite, pyrexia, and abdominal pain. There are some other adverse effects that we can see listed here, but importantly, evidence to date suggests that most treatment-related TEAEs were reported within the first 90 days after infusion. So now that we've talked about functional outcomes and dystrophin on muscle biopsies and adverse events, let's shift gears to another biomarker that we can use, MRI. MRI was explored as a non-invasive method to monitor DMD disease progression. And endpoints in the EMBARK study included muscle fat fraction as assessed by MR spectroscopy and MRI, as well as muscle T2 signal. So I'm going to show exploratory analyses at week 52 of muscle health and changes in the muscle pathology as assessed by the MRI findings. Here we see that change from baseline to week 52 in the MR spectroscopy fat fraction was demonstrated to be in the treatment group a smaller increase compared to the placebo group. And this was demonstrated in the soleus muscle as well as the vastus lateralis muscles that were examined with MR spectroscopy. If we look here in the fat fraction percentage at week 52, we can see that the treated group had smaller increases compared to the placebo group in the measured muscle fat fraction content across all of the muscles that were examined. And if we look at the T2 weighted images in the MRI of the muscles that you see listed here, we see that in 4 out of 5 of the muscles, the treatment group showed a decrease, whereby the placebo group showed an increase or worsening across all of the 5 muscles that were sampled. In conclusion, the 2-year results from EMBARK indicate stabilization or slowing of disease progression compared to this well-matched external control cohort and functional outcomes that you see listed here. In addition, biopsies showed sustained microdystrophin expression up to week 64, which demonstrates durability of delandistrogene moxeparvovec treatment effect. 2-year safety outcomes were consistent with prior experience from the program. And muscle MRI changes were congruent with secondary functional outcomes from EMBARK Part 1 at 52 weeks, showing stabilization or slowing of disease progression in treated patients. We know that delandistrogene moxeparvovec is currently in the US approved for patients 4 years and above, but it's important to know that there are clinical trials underway in patients who are under the age of 4 years. Previous data has already been shared about the 4-year-old cohort from the clinical trial 103. In addition, there is another cohort involving 2-year-olds from the 103 clinical trial program as well. So we have 2 and 3-year-olds in that clinical trial program. And there is a clinical trial program called INVOL, which is ex-US, currently exploring treatment in children under age 4 as well. A total of 23 patients have already been involved in that clinical trial program under the age of 4 and have been dosed. With that, I'll conclude, and we'd like to thank the patients and their families for their participation in this very important work, and we're very hopeful for what the future holds.
Thank you so much. That was phenomenal. So I think you get to stick around, and we're going to ask our other presenters to also join us, and we're going to do a little bit of Q&A here. So first of all, I just want to thank everybody for these presentations this morning and remind everybody of our format. We're going to do Q&A with the researchers who've already presented, and then we will have 3 more presentations and another Q&A discussion with the next 3 presenters. So if you have questions, please put them in the Q&A box. Because the point of today's presentation is to help inform the evidence review that is ongoing for the nomination of Duchenne for the Recommending Informed Screening Panel, we are going to be prioritizing any questions that come in from the evidence review group members today. But additional questions that we may not get to, we will try and address and answer when this presentation is posted. So we just want to make sure if we don't get to your questions and we run out of time, we will try and address those. And we thank everyone for being here with us today. I mentioned at the beginning that this is a quickly evolving space and we are learning as we move, and there are always publications coming out that are informing what we're doing. To that end, one of the presentations this morning had information in it that was based on a publication that has since been updated. Megan had a slide that included information that there's a publication that's been updated since her slide was produced. And I believe someone from the PPMD team had maybe given her a publication that's been since updated. So I just want to provide the updated information so that's available. And before we post the slides, we will make sure they're corrected and updated. But there are currently 8 FDA-approved therapies for Duchenne muscular dystrophy specifically. 7 can be administered before the age of 5. So just want to clarify that. There are 4 exon skipping therapies that are available for all ages. There are 2 steroids that are approved specifically for Duchenne that are for ages 2 and up. And there is 1 gene therapy that is approved for ages 4 and up. So just to clarify that. Okay, so with that, we're going to go into some questions. And if I miss anything, Catherine's going to help me make sure that I catch questions that I'm not seeing come in. So first, I'm going to start with Lauren. So Lauren, thank you for your presentation. Were there siblings in the registry from which case reports could be made exploring outcomes?
Yeah, let me get to my notes on this because I thought it might come up. So we took this question very seriously. We know it was of interest to try to identify sibling case reports or sibling data. So we did work down this avenue. Our registry includes at least 59 non-twin male-male sibling pairs. We identified that based on algorithm, and then that was subsequently hand reviewed by registry coordinators. But when looking to see if those sibling pairs had the appropriate data for the questions we were asking, that's where we didn't necessarily have sibling pairs available for use. So for example, if we're requiring and need to understand their age of loss of ambulation, their age of steroid initiation, those data points were only available for a couple sibling sets. I think 4 sibling sets had both of those data sets available or data points available for both siblings. And even among those 4, there were none who started steroids before the age of 5. And so the further, like the more criteria we apply, like, okay, we want siblings, we want this, the pool gets limited enough that there just wasn't data to produce, even from a database as large as the registry.
Excellent. Thank you. Okay, leave your data set up because I'm going to ask you another question that you're probably going to want to look at it. So we're going to have a presentation later from Holly PA, who's a part of our RTI team. And that team analyzed data for a larger project that incorporates data from 4 of our certified Duchenne care centers, which includes Arkansas Children's, Cincinnati Children's, Vanderbilt, and UMass. Did you notice much of your cohort came from these same clinics?
We did look at this and analyze this. We think we have 11% of our cohort that reported that is one of their primary neuromuscular centers. So that's 89% that wouldn't be at that center at all. And of course, we would not necessarily know exactly what the data match is there. That's the maximum potential data match if that was a perfect one-to-one.
Okay, great. I have one last question for you before I'm going to move on to someone else, and then I see some questions coming in, so I may come back to you. So stay tuned. But can you just talk about outcomes such as bone fragility or behavior side effects? Is the registry collecting information like that? Are you able to analyze for that type?
So the registry data is not necessarily both in like content, like actual questions and structure, and in just sheer amount of data, like the questions people answer to answer really targeted questions about like side effects, right? So for example, we ask about behavioral health diagnoses, like, do you have a diagnosis of ADHD? Do you have a diagnosis of autism? But they're not timed, for example, with any specific age, like when they started steroids, when that appeared, did their symptoms improve in relationship to that? And similarly, now, I am not a physician and certainly very far removed from endocrinology, but my understanding, for example, thinking about bone health and steroid initiation, my understanding is that impact to bone health would depend on a lot of factors about the steroid use, the kind of daily doses being used, the like long-term like cumulative dose, like how long you use them. And so again, while we can understand who is using steroids and when they have started steroids, we do ask a dose question, but we do not have line of sight to truly what is their cumulative usage based on the type of data answer. And then once we start asking, okay, I want this, I want this, I want this, I want this, the N again shrinks very rapidly. So I just don't think we're designed to get at that.
Excellent. All right. Thanks so much, Lauren. The next question is really for everybody, and maybe for whoever can answer it. And maybe this is a question about what has been collected and analyzed previously, and then maybe even leaning forward, what are you able to collect and analyze going forward? But did any of your data sets or studies examine differences between groups in socio-demographic factors that can influence healthcare use and outcomes, such as parental education, family socioeconomic status, race, and ethnicity? Can any of you speak to this?
I will say that in the natural history slides, there are, I do reference 3 articles from Mann et al., Thomas et al., and Counterman et al. that looked at, explored the impact of race and ethnicity on time till diagnosis. So I have yet to see anything specific to the community of Duchenne on parental SES, things like that, parental education. But I know broadly that in families with lower SES, there's plenty of research that says that healthcare outcomes are impacted. But not necessarily within the Duchenne community.
Thanks, Megan.
Yeah, that's from the second paper that we did through the MD StarNet, the CDC funded surveillance study. We know that there is not only a persistent diagnostic delay in general based on surveillance methodology, but when we look at race and ethnicity, that makes the delay not only for diagnosis, but also for offering and initiating corticosteroids also later in those ethnic minorities. So I think there is quite a bit of data out there about that.
Great. All right. Thank you. Dr. Schiffelini, while you're unmuted, can I ask you, can you explain a little bit more about how the matching and balancing the characteristics from the two different trials works?
So it seems like we heard a little bit also this being used in the gene therapy trials. So basically, because we're comparing patients from different trials in this particular work, but also when, for example, you want to compare with an external natural history cohort, you really want to match the baseline characteristic for those characteristics that we know that they're very important in predicting outcomes, right? You want to study outcome and compare, you need to make them as similar as possible and matched. So the propensity weighting, it's a step above a straight one-to-one matching because it allows you to use everyone by weighting them differently. For example, in our study, you know, subject with profiles that were underrepresented in the Polaris DMD study, they were weighted higher and vice versa, so that they overlap at baseline quite nicely. If you do just ranges, you know, you can have the ranges are the same, but with an equal distribution. So this propensity weighting really makes the match. And this has been published. I'm not a statistician, so I don't know if this makes sense, but that's the best way that I can explain it, that is really to adjust for other factors that could be confounder when you look at the outcome, in particular in my study at 12 months.
Super. Thank you so much. Crystal, I'm going to switch over to you for a second. So I'm really interested in, I think the whole community understands, I certainly understand, that the gene therapy for Duchenne was actually the first gene therapy that was approved through the accelerated approval pathway, which was a big moment for the Duchenne community. And it's now been converted to a traditional approval. And so I would be interested to understand how or whether this data speaks at all to the original approval status and the subsequent change in approval status.
So this is new data that we're sharing with you all today, hot off the press, and it's incredibly encouraging, and I think I'm very supportive of where the label sits in the U.S. being 4 and above, because we do see statistically significant differences in treated versus untreated groups when we look over this 2-year time period, not just for the original label of 4 to 5-year-olds, but for all of those ages that were included in the clinical trial program. And as I mentioned, this is also being explored in children who are under the age of 4. And I look forward to being able to share that data in the future as well, because I think that will help guide some of our treatment decisions and also be able to provide opportunities for early intervention if it looks like those are efficacious.
Excellent. So first of all, thank you to everybody for sharing all of the data that you brought forward today. I know for many of you, this was the first time data was being shared here today. And hopefully you'll be able to stick around for the rest of this. And if not, as other questions come in, we will share them with you. There were a lot of questions that came in that we were not able to get to. So we will make sure that those get addressed and posted when this webinar gets posted. So thank you for being with us. And we are going to transition to our second block of presenters. Thank you, everybody. Okay, so for the next portion of our symposium, we are going to be starting with a presentation from Benjamin Tan. Benjamin is a second-year medical student at the University of Arkansas Medical Sciences, UMAS, in Little Rock. He works under Dr. Arvind Veerapandiyan, who's doing research in the field of neuromuscular disorders at UMAS's sister institution, Arkansas Children's Hospital. So welcome, Benjamin. Thank you for being with us.
Yes, thank you for having me. I'm going to share my presentation really fast. My apologies, it's a little technical.
Take your time. There we go.
There
It's
we
in
go.
presenter mode. So if you maybe want to, there you go. Perfect. All right, great. Thank you. Take it away.
Everything look great for you?
It looks perfect. You're good to
All
go.
right. Oops, my bad. All right, so good afternoon, everyone. My name is Benjamin Tan, like she said. I'm coming to you here from UAMS in Little Rock, Arkansas, and I have hopefully an interesting project to share with you guys. All right, just for some background, in 2000, the average age of diagnosis was 4.9 years, as Dr. Cefaloni et al. Published back then. In that paper, it also stated that the average delay of 2.2 years between the onset of Duchenne's muscular dystrophy symptoms and the time of definitive diagnosis. And according to two other studies by Mohammed et al., which was a repeat audit, and then a study by Thomas et al. Using a cohort of data collected between 2000 and 2015, that 2.2 years had really remained relatively unchanged over the past 2 decades. This delay results in a loss of opportunities for early intervention and initiation of corticosteroid treatment, multidisciplinary care, genetic counseling, and possibly enrollment in clinical trial programs. And in the state of Arkansas, the Duchenne's muscular dystrophy is not part of our newborn screening panel. Adding it to the newborn screening panel would allow for an earlier detection and enabling more timely interventions and potentially changing the course of the disease progression. All right, so the objectives of our study was really to assess how the relationship between the age of diagnosis and the initiation of treatment affected the disease progression of DMD patients. More specifically, how the diagnostic delay affected the patient's progression to non-ambulatory status. As far as our methods, this was a retrospective chart review of patients with DMD that were followed at Arkansas Children's Hospital. I just wanted to note the overlap with the RTI study. That study does overlap with this one. However, our scope is slightly different in that the RTI study was capped at patients born after 2017, I believe, whereas this study encompasses all DMD patients that have passed the Arkansas Children's since the 1990s. Their zip code, the distance in miles to a tertiary medical center, which we are
Oh, Ben, it looks like we might be having some technical difficulties with your audio.
Perhaps should we see if our next presenter is ready and then maybe come back to Ben?
I think that we can do that. Dr. Tian, I think I see you in there. I'm going to promote you to a panelist.
I know there are a lot of storms moving through the area, so it's possible that that is happening right now. Again, thank you everybody for your flexibility. We know there's a lot of weather occurring today. Okay, I think we're gonna see whether Dr. Tian is available. Okay, great. We're gonna get started. So our next speaker is Dr. Swisha Tian. And Dr. Tian is a board-certified pediatric neurologist specializing in neuromuscular diseases. She's an associate professor and attending physician at Cincinnati Children's Hospital, co-director of the Comprehensive Neuromuscular Care Program, and clinical director of both the Certified Duchenne Care Center and Muscular Dystrophy Association Care Center. She also supports clinical trials and research in pediatric neuromuscular diseases. Welcome, Dr. Tian.
Thank you. Thank you so much for the invitation. And it's very exciting to see all the hot off press research been going on. So I'm going to share my slides. Can everybody see it?
We can. They're not in presentation mode yet. So if you just want to start, there you go. Perfect. You're ready to go.
Perfect. Got it. Yeah. I'm going to present a sibling case that's followed in our clinic. I feel like it's very unique and really an exciting case to show. So this is my disclosure. And this is two siblings with genetically confirmed Duchenne muscular dystrophy and presented with distinct clinical outcomes. So the older sibling, he was diagnosed at age 6 years, 11 months. He had toe walking, declining motor function, and most noticeable for parents is after age 5. He had a very prominent pelvic girdle weakness on initial evaluation, and the genetic testing further confirmed the Duchenne variants with one base pair duplication, a codon 3408, and muscle biopsy showed dystrophic findings with degeneration fibers and fatty changes, and also with a DIS123 antibody staining showed either absent or slight weak staining, and all the ultrafilm staining also showed a weak staining, which is consistent with Duchenne muscular dystrophy findings. Western blot further testing confirmed 0% of dystrophin protein expression. Daily steroid was started at age 8 years and 6 months. So he's unfortunately a relatively later diagnosis and a later treatment start with steroids. And he did not get any chance to participate in clinical trials. So maintenance with supportive care and steroid treatment with follow-up in clinic with multidisciplinary care. And the younger siblings, who is actually 9 years younger than the older sibling, he was diagnosed at age 4 months because of positive family history in the brother, and he did elevated CPK levels that was found shortly after birth. Genetic testing confirmed the same mutation, and because his age, we were able to prepare the family, education, and get ready for studies of steroid treatment, and family really want to participate in trials. Get him enrolled in 2 trials, actually. First, he was in the catabasis in DEXA trial around age 4 to 5 years age. And after the trial terminated, he started on prednisone daily treatment and shortly after. And at age 7 years and 10 months, he got opportunity and he was enrolled in the DEXA trial, in the EdgeWiles trial. So clinical outcome, looking at the older siblings, he had a North Star Ambulatory Assessment score of 14 at age 9. And he subsequently lost ambulation at age 12 years and 4 months. The younger siblings that he's ambulating really well at age 9 years and 6 months as the most recent clinical visit, and his North Star score at the visit is 32. So as Dr. Shalvana mentioned before, and the North Star skills total count is 34. So 32 out of 34 is a really good score. He only had a very mild one-hand push on his knees when he get up on the gowards. And another one is when he does heel stand, he has a slight compensation with knee flexion. That's where the 2 points taking off. And so this case of the siblings illustrate very distinct and much better clinical outcomes in the younger siblings with earlier diagnosis shortly after birth and opportunities to be able to participate in clinical trials. And I think this is a really positive case for the younger siblings to have. Family are really, really happy at how he's doing at this point. So that's my presentation. I want to thank you all for the opportunity to present this case and welcome for any questions. I'll be stick around.
Thank you so much. We really appreciate you being able to join us today and hope you'll be able to join us for a Q&A discussion in just a couple minutes. Thank you so much, Dr. Tian.
Yeah.
Okay, we are going to stick with our flexibility, and we understand that Benjamin lost power, and so we're not sure if he's been able to get his power back due to the storm. So if he is, we'll be able to pick up that presentation where we left it off. If not, we'll load it into the presentations before they're posted. We also understand that Dr. PA has been having a lot of storms and power outages, so I just want to see whether she's able to join us. Aha.
It
Okay.
looks like we've got Benjamin back on too.
Okay, why don't we move forward with Holly while I see her popping in. Holly, I'm going to do your introduction. I just want to hear your voice, make sure you're going to be able to join us.
Can you hear me?
I can. All right, let me do your
All
introduction,
right.
and then we'll give Benjamin a minute to get resituated. Okay, so Dr. PA has also been a part of our newborn screening efforts in Duchenne for a very, very long time. In fact, helped lead an effort to see whether or not we could circumvent the diagnostic odyssey through early intervention services at the 6-month time period through an early intervention program that she led through CDC long before we approached this through newborn screening. And we found that that very comprehensive effort did actually indeed not change the diagnostic odyssey in Duchenne. So we thank Holly for being a part of this effort with us. Dr. Holly PA is a senior research scientist at RTI International. Dr. PA has a long interest in Duchenne muscular dystrophy with research spanning patient preference and experience studies, neuromuscular surveillance, newborn screening, and studies of psychosocial and clinical outcomes. So welcome, Holly.
Thank you. Catherine, are you displaying these slides? You want to run through, or you want me to? Okay, perfect. All right. So the storms are also going through my region. We're actually on a tornado watch, and I tried to record these slides really quickly earlier, and it apparently didn't work. So we're all going to cross our fingers and hope for the best here on this. So as indicated, I am here to talk about the impact of early initiation of steroids on progression of Duchenne muscular dystrophy. Thank you for the nice introduction, Annie. Unfortunately, we still hear a lot of discussion about these efforts to improve early diagnosis. And it really is a shame how intractable that problem has been outside of the potential for newborn screening. So I'm glad to talk about these results we have today. Next slide, please. So going to the methods and aims of the study, used retrospective longitudinal data that were collected by 4 clinics, and you've heard a bit about that already. This is a study that is only possible because of the clinical data shared by University of Arkansas, Cincinnati Children's, University of Massachusetts, and Vanderbilt. So we gratefully acknowledge their contribution of data to this project, and I will talk a bit about those combined data. As you've already heard a bit about as well from Benjamin, in this project, we cut eligibility to biological males diagnosed with DMD who'd been followed since 2017 or earlier. So we did require a relatively, long follow-up for those individuals included in this analysis. We did conduct our analysis using restricted mean survival time regression, and I'm going to come back and talk a little bit about why we use that analysis in a second. Individuals who initiated steroids after age 12 were excluded from this analysis, and that is at 2 standard deviations of the mean. And again, that's something we can talk more about if folks are interested, but they were excluded from the analysis that you're about to see. And our overarching aim was to assess whether glucocorticoid initiation at different age groups is associated with prolonged ambulation, which here we define at time of full-time wheelchair use. And those categories for steroid initiation that we used were before age 4, between the period of 4 to 5, and then after age 5. So we compared those different groups. Going back to the, sorry, Catherine, just real quick. Going back to the regression model that we use for survival. We started by using a proportional hazards model for our analysis, and that is a very typical kind of analysis done for data like this. But we actually found that the proportional hazards assumptions didn't hold for our model, and that is what prompted us to use this restricted mean survival time regression. But one of the things we actually really love about this modeling is that, number one, it doesn't require the same requirements of proportional hazards, but also what we get out of this kind of model, which you're going to see in a moment, is that the treatment effect is interpreted as a difference in mean survival time. So it's a very easy kind of method to interpret the output, and the output is clinically relevant. So we'll show you that in a bit. Excuse me. So I'm going to talk you through the results here, just very high level. The individuals included in this analysis, we had 783 who were included, and you can see the counts by site. The majority of our respondents came from University of Massachusetts, by Cincinnati, followed by the University of Massachusetts, Vanderbilt, and Arkansas. So again, we are greatly beholden to those clinics for providing the clinical data that allowed us to conduct this analysis. Next slide. So you can see, based on this table, data about race, ethnicity of the individuals included. The majority of the individuals in the study were white and non-Hispanic, consistent with the clinic populations and the data that we obtained from the site. The average age at diagnosis in months was 57.2 months. Most of the individuals were reported to us as currently taking deflazacort. So you can see about 72% of them are reported as currently taking deflazacort. And the majority of them are also currently reported as using wheelchair full-time. That is one of the pieces of data that prompts me to talk just quickly about the limitation. So chart review and data from electronic records can be tremendously helpful in allowing us to do multi-site comparisons and multi-site studies like this, but it does come with some limitations. And so, it's just something that we need to keep in mind as we use data from clinical review, is that there is sometimes some ambiguity or some lack of cleanness in that data, and that is just a part of this type of analysis. And so I'll show you in the next slide. You can see some of that if you want to hit to the next slide. So this shows two different distributions. So the first is the age at steroid initiation. The mean age at steroid initiation in this set of individuals was 73 months. Again, this is all in months, with a broad standard deviation. So we have a relatively broad set of different ages at initiation. And while it's skewed, it's a relatively normal distribution. So we are seeing a distribution across age ranges, reflecting different things, including likely variation in severity, but also differences in prescribing patterns across different providers and clinics, and difference in steroid acceptability for families. You also see, back, Catherine. You also see the age in months at full-time wheelchair use. And, this is where some of that kind of messiness that can happen in chart review is reflected here. The age at in months at full-time wheelchair use, the mean here is 159 months. And you see a pretty broad standard deviation. And if it's helpful, the median there is 150 months. So we are seeing a pretty, again, broad set of data in terms of the age at full-time wheelchair use, and that is the primary outcome that we use in the analysis that you are about to see. Next. Okay, so here is our assessment of time at loss of ambulation. In this analysis, we included age at diagnosis in the model, and that was a proxy for disease severity, with the anticipation that boys who have more severe disease will show symptoms earlier and be diagnosed earlier than boys who have less severe disease. So it is not a perfect proxy, but we did include it in our model as a control. And so what we found in this model is that boys who started steroids after age 5, so remember we had 3 categories. This is our oldest category at steroid initiation. They lost ambulation 11 months earlier than boys who started steroids before age 4. And that is controlling again for age at diagnosis. So the p-value here is 0.19. So we did not hit the significance p-value, but we are seeing a trend toward later ambulation for people who start steroids earlier. And the second age group that we looked at, again, is that 4 to 5 and compared that to before age 4. And so people who started steroids between 4 and 5 lost ambulation on average 7.7 months earlier than those who started before age 4. And again, we see a non-significant p-value, but a trend toward having improved ambulation with earlier steroid initiation. Next. So I'd like to acknowledge the team. Again, this is a collaboration that could not have been possible without PPMD, who organized and funded the study, and importantly, the clinical sites who provided the data. The analysis was done by myself and my colleagues at RTI International. Next. I think the last one is just the pretty slide. Yep, thank you. There, my email is here. I'm happy to answer questions by email, but I know we have a question and answer session that will follow.
Holly, before you hop off, we received just a clarifying question that I think would be able to ask you now. What is the definition of full-time wheelchair use that you utilized?
Yep. So we actually had two different pieces of data that we used there. One was a yes/no that we asked the clinics to indicate for us whether the individual was in full-time wheelchair use, and we asked for a date. And so we used both of those data points. So of course, we shouldn't have a situation where someone says no and has a date where people initiated wheelchair use. So we did both of those data points. We did some data cleaning with the sites where we indicated some differences in those 2 data points. But it was both a dichotomous yes/no, and it was a date of initiation that we used.
Okay, wonderful. All right, super. Thank you. All right, we look forward to more Q&A in just a moment. Thanks. Okay, I think next we do have Benjamin back, and so we are going to ask him to pull his presentation back up.
Sure.
Hopefully your power is back up.
I'm so sorry about that.
No, we understand. Thank you for being back with us.
Yeah, glad to be back.
Okay, why don't you pull your slides back up, and thank you for your fortitude. We appreciate it.
All right. It seems that I left off on my methods, if I remember correctly.
Yep, perfect. Why don't you just start at the top for this one? All right, thank you.
Yeah, sure. Okay, so as I was saying earlier, this is a retrospective chart review of the patients with DMD that were followed at Arkansas Children's Hospital. And again, that note on the RTI study with the RTI group being born after 2017, whereas our group is patients consisting of all DMD patients who have passed through Arkansas Children's since the 1990s. These following variables were collected: that is age of diagnosis, age of onset, the time between onset and diagnosis, the age at start of multidisciplinary care, age at start of steroids, age at loss of ambulation, which we define as full-time wheelchair use, zip code, distance in miles to a tertiary care center, of which we are the only one in the state, and the genetic mutation that the patients had. Logistic regression was used to evaluate if time between the age at diagnosis, at onset of symptoms and diagnosis were associated with the loss of ambulation. This was analyzed using a multivariate and a univariate logistic model. And the age at start of steroid treatment and the demographic variables were also examined for association with loss of ambulation. Okay, let me just walk you through the results. I know there's a lot of numbers here, but this just depicts our general demographic information for the patients in our data set. This includes the studied population's racial demographics, average ages of diagnosis, onset, start of care, start of steroids, and loss of ambulation. Our study consisted of 78 patients, 40 of which who were ambulatory and 38 who were not. I just want to highlight the average age at diagnosis being 4.6 years, whereas in that article that I referenced from 2000, it was 4.9. The average age of onset of symptoms being 3.2 years, and the average age at start of steroids being 6.4 years. As far as the steroids, the mean age at the beginning of steroid use for ambulatory patients was 5.6 years, whereas with non-ambulatory patients, it was 7.2 years. I just want to quickly highlight that the majority of our patients were white, with 52 patients being white, non-Hispanic. 15 were Hispanic patients, 4 were Black patients, 2 were Asian or Pacific Islander patients, and 5 were, their races were unknown. All right, this chart just shows it plots the number of patients who had lost ambulation, that's in red, and the number of patients who are still ambulatory in blue, and compared against their ages of diagnosis. As you can see, the ages of diagnosis in the patients who had lost ambulation is consistently older than the ages of diagnosis of patients who had not lost ambulation. In fact, the average age of diagnosis was 3.6 years for the ambulatory group and 5.6 years for the non-ambulatory group, with a 2-year difference between the groups. You can appreciate how the red curve is shifted to the right, indicating that big 2-year delay in diagnosis for the non-ambulatory patients. All right, another table with a lot of numbers. This is the degree to which our studied variables correlated with positive ambulatory status according to the univariate logistic model. All variables showed a moderate positive correlation except for the distance to the clinic or hospital, although that was the only factor that was not deemed statistically significant. Okay, and this table just shows the odds of white non-Hispanic patients reaching loss of ambulation was actually 3.8 times greater than those of non-white race or Hispanic ethnicity. Okay, to summarize, older age of diagnosis and white race was significantly associated with loss of ambulation. The patients who were diagnosed at older ages consistently showed higher degrees of loss of ambulation, while patients diagnosed at younger ages tended to remain ambulatory for longer. White non-Hispanic patients had higher odds of non-ambulatory status in our group as opposed to other racial groups. For every 2-year increase in the age of diagnosis, we found that the odds of loss of ambulation actually increased by 2.6 times. Upon univariate analysis, the age at onset of symptoms and the start of steroid treatment were actually significantly associated with ambulation. However, in the multivariate logistic model, only age of diagnosis and white race were significantly associated. Further studies with larger sample sizes are needed to better elucidate this relationship. And I'd just like to acknowledge Dr. Panda and Dr. Spray, who have given me the opportunity to work on this project and gain exposure into this field, which I had a little experience with beforehand. And Dr. Spray had drawn up all the statistics and did a lot of the heavy lifting, and this project wouldn't be what it is without him. I'd also like to thank the Parent Project for allowing me to speak at this conference and giving me a platform to present my work. And obviously, this project wouldn't be anywhere without the patients in the cohort, which we are deeply grateful for. Thank you.
Thank you so much, Ben. We know that you're going through a lot right now. So thank you so much for your patience today and for getting back on with us. We appreciate it. Okay, so we are going to ask all of the presenters from this block to join us. So if Dr. Tian and Dr. Pieg join us. Okay, super. And we've had a number of questions also come in through the chat. So we're going to get through as many of these as we can. I think the first one I'm going to ask is, let me first ask Dr. Tian, and if anybody else wants to speak to this also once she's finished, please do. But I'm particularly interested in your experience with siblings within your clinic? Are there other sets of siblings who've had similar outcomes?
We do have probably 40 some set of siblings in clinic, and with this many years of follow-up, in the total about 800 Duchenne in the registry. Yeah, and this is one of the very uncommon siblings because one is the age difference from the older ones and the younger ones. So there are difference in terms of opportunity of treatment, clinical trial. So I think this is one of difficult to replicate one. And there are other siblings that in the clinic we do see some of the younger siblings are work better, but not as good as this one showing as well. It's a 32 out of 34 North Stars, pretty rare, I think, for Duchenne boys at age 9. Yeah, so this is one of the unique cases. I want to highlight the clear difference in terms of the age of both siblings, also the opportunity of treatment or research. Yeah, we do have other siblings there.
And you are also, and it sounds like you're also collecting data, though, on those other sibling cohorts in your clinic as well.
Yes, we do have a registry. We've been tracking the siblings. We try to take an attempt to look at what's the differences in terms of their motor function changes as well.
Super, great.
Hopefully we have more to report. Yeah.
Super, thank you. So speaking about data collection and trends that we're seeing, there was a question from earlier that I'd love for anybody here who would like to speak to it. One of the question that came in was just an observation that it seems that steroid treatment effect is diminishing over time, and the question around whether or not there's work being done on understanding whether or not steroids should be discontinued at some point. So is anyone here able to speak to ongoing work around the longevity of steroid effect and how steroids should potentially be tapered and discontinued?
I think in clinic, we hasn't been attempt to doing steroid tapering. I think there's no data and to recommending it, and still quite short time data, especially with gene therapy long-term. Maybe Dr. Prod has more experience with that because she's a trial site and has more experience with gene therapy in terms of steroid. And I know there was, cases people talking about change from deflazacort to vamorolone post gene therapy. Within a short period of time, there were changes of motor function or elevated CPK levels. So that's quite a bit we don't know yet in terms of steroid regimen to adjust post gene therapy. Yeah.
Yeah, I think your point about it's still, we're learning a lot. It's early days. And also there's a lot we don't know about individuals who are identified early, like in a timely way under the age of 5, and what the ongoing optimization of outcomes can be with ongoing exposure to therapy. Holly?
I'm not the right person to talk about the sort of clinical long-term recommendations for use. I know there is some literature there, but I'm definitely not the right person to speak to that. But I will say that in collaboration with PPMD, gosh, I think it was probably 3 years ago now. I can put the reference in the chat. We did a study looking at perceptions of steroid risk and benefit from caregivers and people living with Duchenne, and that included adults. And so we did ask the community their perceptions of that kind of ongoing benefit risk profile, and that, so there is some of that data available, and I'm happy to put that in the link if you think that would be useful to the group.
I think that would be terrific. Thanks, Holly. So can I also, Holly, while you were available, there was also a comment in the chat around the observation that starting steroids earlier could relate closely to demographic and care resource availability for patients and families, being able to impact outcomes. Can you speak to that?
Yeah, absolutely. And the way I'm going to speak to it is the reason why we did not control for that in our analysis. Okay, so we know from existing data that there are some differences that, to my knowledge, are not fully explained about some phenotypic differences that we see that have influence of race, ethnicity, that may be access issues, they may be other issues, other sort of genetic factors. But we did not control for those things in our analysis for this reason. Those things are incredibly important for long-term understanding of natural history and trajectory. We don't think they're important to understand whether we should be doing newborn screening. If we are, newborn screening is for everyone. And so what we want to know is on a population level, are we seeing benefit on a population level, right? And once we do screening on a population level, then we are in an excellent position to do very detailed studies of natural history, of impact of different treatments, and look very specifically at those kind of moderators and confounders that will impact the relationship after a child is diagnosed in an equitable way at the same time. Because right now it is really difficult to know if some of these challenges that we're seeing and differences to access and differences in outcomes is based on differences in diagnosis, differences in treatment, and newborn screening will help us answer those questions. And so to get to newborn screening, yes or no answer, we really feel pretty strongly that we should find out whether there's benefit at the population level and then use a better cohort to be able to understand some of these differences that are driven by demographic factors.
Super. Thank you.
Is that an okay answer?
I think that's a terrific answer. Thanks, Holly. And then the last question is one that I can maybe help answer, but I'll pose it to the rest of the group. It came in from, I think it's a physician regarding the question is regarding gene therapy. There's curiosity around whether there's a need to advocate for coverage and reimbursement. The questions within Medicaid for coverage and reimbursement for gene therapies. I'm going to maybe kick this off and say that we are seeing pretty comprehensive coverage and reimbursement within the Duchenne space for the approved therapies in Duchenne at this point, which is taking some advocacy from the patient community and from providers who are advocating for patients. At this point, we are seeing reimbursement and coverage for the approved therapies. I also, though, will point out, and so the question talks about that sometimes these treatments can be very expensive for families and wanting to avoid out-of-pocket expenses, which is something that we as a community are very concerned about. But we are also very concerned about the fact that living with Duchenne is cost prohibitive for families in general. And so reimbursement for all of the care necessary for Duchenne is something that the community has been advocating for a very long time. And that the reimbursement for equipment, caregiver expenses, modification to homes are things that we have long also been advocating for. And as a community, we've been trying to collect a lot of data around what are the costs associated with living with Duchenne, which of those costs are currently being reimbursed, where there are barriers to reimbursement for those costs, and which of those costs are currently just shouldered entirely by families and communities and are not currently being reimbursed. Specific to newborn screening, we have also done some work, and I've done some work with the Every Life Foundation to understand where are the avoidable costs by reducing and eliminating the diagnostic odyssey. There are costs inherent in the diagnostic odyssey that can be eliminated by newborn screening. So when we have families that have a diagnostic odyssey of 3 or 5 years, there are costs within both the direct medical system and the indirect and non-medical aspects of that journey that can be eliminated through newborn screening. And we also have health economic data around that as well. So we do think that that's a really important aspect that needs to be considered, and that this is something that's incredibly important to the provider community and especially to the patient community. So we thank you for raising that, and that's something that we are certainly collecting data around. And then I think the last question we'll end on, and this may be something, Holly, for you to address, because I know you've helped collect some data around this, is the question of parental expectations and what type of work has been done to either collect data or understand the patient journey and patient expectations and prepare for resources for parents and providers once a child has been diagnosed with Duchenne. The question specifically says when there are no treatments available for someone under 6 months old, although there are treatments that are on label under 6 months old. But maybe you can speak to some of the work that has been done, and you specifically led some of that work to have some patient and provider facing materials available. So do you just want to talk about what is available for to support families?
Yeah, I will reflect that it is a challenge, and that's a challenge in newborn screening more generally. This is not a Duchenne-related challenge. Is when we start to diagnose children more earlier in the disease course, especially at newborn period. We can sometimes end up in a situation where clinicians say, "Eek, I'm not used to seeing these kids until they're 3. What do I say now?" to their families. And similarly, groups like PPMD need to develop resources specific for people who are diagnosed in the newborn period or very early when they may have minimal or no symptoms. And so that is a good question. There is this sort of specific time point. And we have heard from families in studies I've conducted that time period is a period where families feel more uncertainty about what will happen to my child long term. My child is still developing normally, and that this is a time when I hear the diagnosis and I believe it, but I don't see it. And so that is a challenging time for families and caregivers. I know PPMD has developed materials for families in that difficult time period. And I know that, it is, again, an area where there are shared learnings across many different newborn screening conditions where the phenotype is not immediately apparent when the newborn screen result would come through. Specifically for treatment of those children, again, Annie, there are treatments available, and increasingly there are treatments available earlier on for conditions we identify through newborn screening. In Duchenne and in other conditions, we do find that families have quite high hopes for those treatments to improve their child's long-term outcome, as one would expect. It is important that there are well-developed materials to make sure that those expectations are in line with reality. So, in a recent study, we did find that parents especially of young children do have an understanding that right now, the gene therapies in Duchenne are not curative, but they do have a high expectation for there being a significant benefit for those treatments. So it really is critically important in shared decision-making that we have robust materials to help families understand what is likely to be a real outcome of a particular kind of therapy.
I think that's great.
Again, did I answer your question?
That's perfect. And since the person who entered the question specifically gave the age point and threshold of 6 months, I think it's just important to remind everybody that there are currently 5 treatments available for individuals who are diagnosed under the age of 6 months for a family and their provider to consider together. And that's including the 4 exon skipping therapies and prednisone. So that would be an option for a family and the provider to be discussing together. So with that, I would like to thank all of our presenters today, especially this last panel who was here for our questioning and endured a lot of power outages and storms for this presentation. So thank you all very much, and invite Catherine to come back and join us for our closing and to provide just a little bit of a landscape analysis of what's ahead and what's happening as far as newborn screening, because while we are really focused on the nomination to the RUSP, there are state implementation efforts underway, and we're just going to spend about 2 minutes talking about what those look like right now. So Catherine.
Absolutely. Thank you to those of you who have hung on while we are veritably besieged by storms. I really appreciate everyone's interest in learning about this really important space. So let's dive in real quick to what the next steps are. You know, we've had this long journey with input from so many valuable stakeholders to get to where we are and to get to the RUSP vote this year. But there is a lot that will be done after the vote. We want to make sure that there is accessible screening, accessible resources for all states that are implementing newborn screening for Duchenne. We want a structure for long-term follow-up, new care resources with a focus on infancy for those clinicians who are meeting these parents when their children are so young and they have questions about what next steps are. And of course, as mentioned by many of our speakers, we are continuing research on treatment under the age of 4, continuing the investigation of non-steroid treatment and what that means for families and for the kiddos. Right now, this is what the landscape in the United States looks like. We have 2 states that have initiated newborn screening for Duchenne, Ohio and Minnesota. We've got a couple states who have signed legislation to begin newborn screening, and then all the yellow states here have some degree of movement and momentum, a bill that has been brought forward or a nomination that has been submitted. So again, we've got Ohio having been our first starter on newborn screening last year in April. Minnesota just started within the last couple weeks. And then we're anticipating a start from New York in the next year or so, and Massachusetts bill asks that they start before June of 2026. We don't expect the process of newborn screening to look exactly the same from state to state, just like with other newborn screening conditions. The tiers of testing, the cutoffs to call CK abnormal will vary based on a state's population and their resources and the validation process. For example, the New York pilot process was based on quite conservative cutoffs. And after the pilot, Norma Tavicoli and her team worked with the Collaborative Laboratory Integrated Reports team, that's that CLEAR acronym, which is, again, a really great resource. It's free of charge, can be used by states that are sharing their newborn screening data. And they compared additional analytes that were already picked up as part of newborn screening. And in doing so, they were able to learn that their false positives on their first tier, the ones that came back kind of borderline and needed to get another CK done, had much higher TSH levels than their true positives. So in their preliminary analysis, they were able to use this ratio of CKMM to TSH and reduce their borderline first tier screens that needed a second screening by 93%. So we anticipate that we are going to continue to learn not only about how beneficial early treatment can be for families, but also about how this newborn screening process can be most beneficial and most precise. States already have some great resources to support their process, and there are more that are coming. So in addition to CLEAR, the CDC's EDEN project is designed to improve disease detection with the data platform and data sharing process that hones these algorithms. And DMD is also included as an actionable condition in genome sequencing pilots across the country, the insights from which will inform many aspects of current programs, such as the family support and clinician education needs. There are also ongoing projects to support clinicians who take care of patients diagnosed young. So MD StarNet is another CDC program that collects and publishes data on all patients with muscular dystrophy. Baby Duchenne was funded by PPMD to develop infrastructure for long-term follow-up and data collection on that very early natural history, which could be shared across the country's clinics. And PPMD and Treat NMD have convened teams of experts and advocates, patient families who have already laid a foundation and continue to flesh out that guidance on the screening, treatments, and referrals that are valuable in very early care. So that brings us to you. This QR code takes you to an extremely quick survey about getting involved in newborn screening. So if you're doing research in this space and want to share, you can hop on there and let me know. If you'd like to sign a letter or attend a meeting about newborn screening, absolutely share that. And if you aren't sure about getting involved, if you have questions or you just want to chat about newborn screening, you can go into that survey and indicate that as well. Or you can email me. I'm helping to support the newborn screening programs at PPMD, and I'm always available to meet with folks who have questions or want to dive into it a little bit further. So with that, I will thank you. I'm so grateful for our speakers and our listeners today. Annie, do you have anything more that you'd like to add?
Yeah, I just want to say a quick thank you. Again, a thank you to all of the forward-leaning clinicians and researchers who had the foresight to lead structured data collection efforts that were presented today. A huge, tremendous thank you to our federal and state public health and biomedical researchers who are leading this newborn screening space. Especially at this time, we are grateful to you for your leadership and your commitment to our community. And a thank you to all who contributed to getting us to today. As I showed at the beginning, it truly has taken a collective for over a decade and a half to get us to this moment. And we are thankful for all who have leaned in together to build our Duchenne newborn screening infrastructure in the US, and most especially to our families who've been working to dedicate time, data, and generations of their families to make sure that we can get here to this moment. We know that newborn screening has the ability to optimize the health outcomes of our children and adults living with Duchenne, but we know that will only happen when we screen. So thank you to all who are here with us today.
Yeah. And as a reminder, the recording for the symposium will be up on our website in the next week or so. So with that, we're going to go ahead and conclude the Duchenne Early Intervention Symposium. Thank you all for joining us. Keep your eye out for that recording and have a great afternoon.